Welcome to another episode of Warriors Unite, the Untold Story. And I feel very excited because my next guest used to be my pediatric doctor. And so I'm very interested to have a conversation today with Dr. Knight-Madden, Professor Knight-Madden, actually. Welcome, Doc.
Thank you. It's great to be here.
So the first thing I would like you to do is tell us who you are.
I'm a pediatrician. So I did medicine in Jamaica and Barbados, and then I did pediatrics at Sick Kids in Toronto. Before I even left, I met with Professor Sargent and said I had an interest in sickle cell disease, and so I wanted to come back to work at the sickle cell unit. When I finished pediatrics, I looked at all the specialists that we had in Jamaica, and we didn't have a pediatric lung specialist. And you know that acute chest syndrome, which is like pneumonia, is a big problem in sickle cell disease. So I went to Duke University and I studied that pediatric pulmonology, or lung problems in children. Yeah. And then when I came home, I did my PhD at King's College in London. And the title of my PhD was actually the impact of asthma on acute chest syndrome and chronic lung disease in children and adults with sickle cell disease. So that's my professional training. So I've been at the unit since then. I was director for a few years and then gave that up a year ago. But what is really interesting is a few years ago, I wanted to study something and I didn't know what it was called. And it took me about 3 years to find out what this thing was. And what it is implementation science. And that is not just medicine, but it's social science and all different things mixed up, which actually looks at how you do your studies, you find out something works, how do you actually implement it successfully?
Yeah.
Because my frustration was that we've done so much research in Jamaica and other places, but yet if you go to Portland or Westmoreland, our people are not really getting the benefit of that.
Yeah.
So I studied that, I did a diploma in that, and with that, I have really not done any studies, but have been using those skills as I work with the Ministry of Health. So the Ministry of Health actually has Sickle Cell Technical Working Group, which is in charge of the process in Jamaica, and I'm the co-chair of that. And that's one of my most important roles right now, because using the implementation science, we're actually trying to get the lessons we've learned from research at the unit to everybody living with sickle cell disease, wherever they are in the island, and to some extent, other countries in the region.
You mentioned other countries. Now, I know you've been to other conferences across the globe. What has the research in terms of treatment been like for sickle cell?
Okay. So I have a slide when I present, which has like different levels. The first thing that we have to know is that diagnosis is the first step of treatment. Because if you don't know they have it, you can't treat them, right?
Yeah.
So in Africa, where very few children are diagnosed at birth, I want to stick a pin right now and big up Jamaica. We screen 99 point whatever % of children born in Jamaica for sickle cell disease. In terms of actual numbers, we screen more per year than some countries that have over 1 million births a year and have more sickle cell than we do.
Yeah.
So the first step is actually to screen. So in some of these countries, they have like what we used to have way back when Prof Sargent was doing a research project.
Yeah.
They have research projects, but they don't have universal screening. So the first thing you need is universal screening, where you then go and pick up the babies that have sickle cell disease and get them into care.
Yeah.
Because the first kind of treatment for sickle cell disease is penicillin, vaccines, and feeling the tummy every day.
Yeah.
For children up to the age of 5.
Yeah.
So if you're born in Jamaica today and you're screened and you come to the unit or to one of the other clinics, your chances of making it to 5 are the same as if you didn't have sickle cell disease.
And that's good.
If you're born with sickle cell disease in Africa today, your chances of making it to 5 are somewhere around 30–40%.
Wow.
And the difference is penicillin, screening, penicillin, feeling the tummy, and vaccines. So that's the next step, right?
Yeah.
Then you go up one step to hydroxyurea. So hydroxyurea was a cancer therapy, and through serendipity, they found out, they said, wait, in hydroxyurea, the hemoglobin F goes up. And in people with sickle cell disease who also inherit a high F, they're not sick.
Yeah.
I wonder if the high F from hydroxyurea would help in sickle cell. And now we have decades of experience to show that it does. To the point where there are some clinics where when you turn 9 months of age, they say to you, your parents, would you like your child to go on hydroxyurea to try to prevent a lot of the side effects and the complications of sickle cell disease? We are not there yet. Where we are, it's now on the National Health Fund, so it's subsidized for everybody. If you attend the sickle cell unit, it's free because you can go to DrugServe and get it. But there's a lot of barriers. People say, oh, it's a cancer drug, it's going to give me cancer. Or, what, I have to take medicine for the rest of my life? Or things like that. But let me tell you something. You see the first hydroxyurea study? Do you know it was stopped?
No, I actually have never taken hydroxyurea.
It was stopped. Do you know why it was stopped?
Why?
Because it was unethical to continue it. So it was a clinical trial. In a clinical trial, you give half the drug and half a sugar tablet, a placebo.
Yeah.
Nobody knows who is getting what. The patient don't know what they're getting. The doctor doing the trial don't know what they're getting. Is only what they call the data safety monitoring board. So they're separate. I'm on a couple of those for projects in Africa now.
Yeah.
They know. And every so often they look at the data. And when they looked at the data, they said, no, we have to stop it because the people on hydroxyurea were so much better than the people who are not on hydroxyurea. It was unethical to continue to give anybody the sugar tablet. So they stopped the study and offered everybody hydroxyurea. And that was in adults. Several studies have been done in children. There are a few people that it doesn't help, but the vast majority of people are better on hydroxyurea in terms of pain, in terms of acute chest, in terms of stroke. So we use it in Jamaica to help try to prevent strokes because we don't have enough blood to transfuse people. And then sometimes we use it for people who have severe anemia. There's some emerging reasons to use it, but pain, acute chest, and stroke, those are well established.
What would be the reason to not give a patient? Because like I said, I've never had hydroxyurea.
Well, in our situation where we are resource constrained, what we tend to do still is offer it to people who are having a lot of pain, a lot of acute chest, or have had a stroke. But if any patient with sickle cell disease comes in the clinic and said, you know, I've read about hydroxyurea and I'm interested in having it, we will give them. And certainly the more severe people, we will definitely offer it. If you have a sibling on hydroxyurea, we will offer it. And as I said, anybody can come and ask about it and we will offer it. But we have not, I mean, if we were to put everybody on hydroxyurea, we'd have to build another clinic right next door to manage the load, you know. But for sure, the plan is that as we strengthen care across the island in the public and private sectors, people will be able to go on to hydroxyurea and their doctor close to them, their GP, their internist, their pediatrician manages their hydroxyurea and really only comes to us if there's a problem. Nice. So I would say that for the vast majority of people with sickle cell disease right now, my feeling is that we should push for hydroxyurea. That is where we need to go. It's if hydroxyurea doesn't work for you, then we need to look at something else because all the other drugs don't work as well, are way more expensive.
That's also very
by
true.
multiples times, right? And so it's unreasonable to say, oh, Ministry of Health, you must bring in all these other drugs when we haven't taken that step of getting everybody onto hydroxyurea first, and the ministry has made hydroxyurea available, right? So it's on the NHF, and it's available through public institutions for free, through the DrugServe.
Nice.
Then there are these other drugs, you know, 3 of them have been licensed recently, and 2 of them, we actually did clinical trials. We were a site, both for Volexator. I'm really bad with the names because I know them as their original names when they were being trialed, right? CellG1 and GBT. And then there's an arginine product which is also approved for use. And they all have their place, but even in, you know, when we talk to our colleagues in the US and UK and Europe, they don't use them in widely just because of cost.
Yeah.
And so the cost benefit, you know, you're really looking for people who have failed hydroxyurea or haven't done well on hydroxyurea, and you're looking for something else to go to that. And then, of course, you can't talk about treatment without talking about cure.
Yes.
Right? So bone marrow transplants are par for the course in places with money, right? The younger you are when you do it, the better it works. But here's the problem. You need a match.
Yeah.
And then so in bone marrow transplants, what they do is they take somebody else's bone marrow. They basically kill your bone marrow, and then they give you that person's bone marrow.
Yeah.
So they have to condition you with some very strong drugs, so you're very much at risk of infection during that time. And if it doesn't take, it's a problem. I mean, the mortality rate is pretty low now in good centers, and the cure rate is very high, but you need a match.
And it's expensive.
And it's very expensive. I mean, we looked into it, and like they do it in Brazil, they do it, but no, not for foreigners. They do, so we looked at it, right? I think the only place you can get it done relatively less expensively is India. So we are part of a trial which is looking at gene transfer, which is that you take your own bone marrow, and in the lab, you put a gene into it, in our case, one that makes hemoglobin F, and then give it back to you. Now, clearly, because it's your own bone marrow, the chances of you rejecting it are much lower, so you don't have to get a strong medication before. And the results have been quite encouraging so far. But now there's talk about CRISPR, where you actually take out genes. I don't know about that yet. I'm not really ready to talk about CRISPR yet because I have to really understand it before I can talk about it. But just from what I know, there's some issues that I would need settled before I can say, oh, it's a great thing, go ahead.
Yeah. I'm happy that there's now a cure because we were taught back then there is no cure for sickle cell. You have sickle cell for life. It's expensive, but it happens.
Right.
So you've been to many countries, many conferences. You would have heard some myths, but what are 2 of those myths that you've heard that you know because you're a doctor, you're also a specialist in this area. What are 2 of those myths that you would love to debunk?
Wow, only 2? Okay.
I mean, you can list as many.
People with sickle cell disease will die by their time they're 25. Well, hello, we have people living into their 90s, right? So the average age that people with SS live in Jamaica is somewhere in the middle 40s, which means that half will live longer than that and half will live shorter than that. Yeah. So that's definitely a myth. Another myth is that women with sickle cell disease are mules. They cannot have children. That's not true. The risk to them and the child is higher than with other children, but they certainly can have children. Another myth is that it's catching. So either the jaundice, yellow eyes, or the leg ulcers or whatever, you can catch it from somebody with sickle cell disease, and we know that that's not the case. Oh, what's another one? Oh, the white cells are eating the red cells. No, nothing like that. The red cells do break down because of the abnormal hemoglobin, but it's not that the white cells are eating up the red cells. Yeah, those are some of the big ones.
Yeah. Thank you so much for being here.
You're very welcome.
It was a pleasure.
Same here.
And it was especially a pleasure because it feels good to be able to do this with you, knowing you know fully what my journey has been. And so thank you so much.
Well, you know, that's the beauty of being a pediatrician, is that your patients get taller than you and outgrow you. So there you go.
Yes.
Great to see you.
Definitely.